All right, welcome to our recording on ketamine. Hopefully we find this insightful, educational, and gives us enough knowledge to go ahead and add this to our medication formulary with a little less trepidation. So we'll talk just a little bit about ketamine in brief here. It was introduced to us in the mid-1970s, and its purpose at that point was as a general anesthetic. To date, that still remains its primary indication, but we have found through the years in trial and error, as we do with many drugs, that it has several different effects just based on the dose. So without further ado, we're going to kind of kick into that. So ketamine operates right on a continuum, right? It's on that sliding scale based on the dose. So at the low range of our dosing scale, we have our analgesic effects, right? And as we go beyond analgesia, we move into the recreational range, and that's where people go to the rave, the club, whatever, and they enjoy the dancing with the music, the colors, right? They enjoy a nice, pleasant trip. When we go beyond recreational, we start to turn off too much of the brain and we go into that partial dissociation. And that's where people can really have adverse events, adverse reactions. They start to have kind of that waking nightmare because too much of the brain has been turned off and now it's trying to fill in the blanks. And it's usually not doing it in a wonderful way. So that's when we start to can get ourselves into trouble. Once we go beyond partial dissociation into dissociated, we've just shut the patient down. We've achieved at least neurologically true anesthesia. You could cut somebody's leg off here and they aren't going to do a thing about it. They're not going to realize it until it's all over and they wake up. Okay, so it's that dosing spectrum that really allows us the flexibility with this medication. Okay. So here we have a better representation of that range. So 0.1, 0.2 milligrams per kilo, that is a very safe analgesic range to have on board your patient. Analgesia does play over into the recreational range as well, and the typical dose for analgesia itself is 0.1 to 0.3 milligrams per kilo. What we have to recognize is that at the high range of analgesia, we can get into that recreational range there, and we can kind of make our patients a little bit giddy, a little bit trippy. Right. If we push beyond there, that's where we can get into trouble with that partial dissociation. So we do have to be mindful of the dose. And then once we hit 0.8 milligrams per kilo and above, and in the typical anesthesia world, you just say 1 milligram per kilo and you've shut your patient down, right? You can't do anything more than turn the brain off, right? Other than turn it off for a little bit longer. Okay? So we have this whole dosing spectrum continuum. All right, so ketamine works primarily by being an NMDA antagonist. And NMDA antagonism shuts down glutamate, which is one of our primary neurotransmitters. That's what helps sends all the signals up through the spinal column. That's what sends a lot of the signals through our brain as well. Okay. Ketamine works by causing that thalmolimbic dissociation. So in an analgesic form, it stops the pain transmission from ascending the spinal column and getting into the brain, or from those signals transmitting through the brain to the pain centers. And then when we talk about anesthesia, right, we have that thalmolimbic dissociation. Basically, we're taking the higher functions of the brain and we're tossing them away. We leave the brain stem intact, which allows the patients to maintain their own respiratory drive and to maintain their own vasomotor hemodynamic maintenance, right? So it's very desirable from a patient safety standpoint in this regard, and has a lot of benefits to our field. Okay, now it's broken down into two primary effects. The alpha effects are anesthesia, but they're short-lived, right? 5 to 10 minutes on average, and patients either require a continuous infusion or multiple redoses to keep anesthesia intact. The beta effects are what we're looking at right now, right? And beta effects really deal with pain transmission, and they last an awful lot longer. At least chemically speaking, they can last around 2 to 2.5 hours. Realistically speaking, we see the primary effect of analgesia from ketamine lasting half an hour to 45 minutes on average. So these patients may require more frequent redosing, but that's okay. Right. The alpha effects, the anesthesia effects, wear off very fast in 5 to 10 minutes. So we are at a really low risk staying in our analgesic ranges of actually anesthetizing our patients, and more just keeping the analgesia going is where we're aiming. Okay, so it's very safe in that regard. Now, Ketamine itself can hit like a ton of bricks. When we look at all of the parenteral forms of administration, okay, so our IV, IO, and IM, it is over 90%, over 93% bioavailable, right? And it hits our patients like a ton of bricks. When it kicks in hard. So you can catch up real quick on your patients. Now, IV, IO, it really takes effect quite quickly as well. We're looking at 60 to 90 seconds to onset. So you'll know really quickly if you're having that effect or if you need to add more. Okay. Now, as we were kind of talking about in prior slides, ketamine does work as an NMDA antagonist. And the reason that we have that analgesic benefit is that what it does is it tries to really shut the pain signal down before it even gets into central spinal stimulation, right? So it doesn't allow that pain signal to transmit up the spinal column to the pain centers of the brain to even be recognized. Okay, so ketamine tries to shut it down before it even hits the spinal column and inhibits the transmission of the painful stimuli. Okay, now there's some benefits to ketamine that we have here, right? There are reasons that ketamine can be beneficial to our patients. Some of those are patients in addiction recovery, right? Think of somebody who's had a bad accident or an injury of some sort, any kind of painful stimuli, and they are begging you not to put them back on the opiate hamster wheel because they are terrified of falling back into their addiction. Okay? Ketamine can be very beneficial in these patients because it does not have any direct opioid receptor stimulation. Okay? Patients with neuropathic pain, because it inhibits the transmission of the nerves themselves, right? This can really be beneficial to patients who have that long-standing pain. You know, they've taken tons of T3s or opiates, all their other medications chronically, and it's overwhelming them. Ketamine can kind of tip the scales for us in these patients. Right? Now, patients who are opiate tolerant, right, who have had long-term opiates or have addiction issues, not saying that we wouldn't necessarily give those patients opiates as well, but ketamine, because it works through that alternative pathway, can become an adjunctive agent and can really help manage the analgesic requirements of patients who already have opiate tolerance. Okay. Same with intolerance. If you have patients who just cannot tolerate opiates, they have bad reactions to them, whether actual allergies or severe sensitivities, and they just would really prefer not to have opiates, ketamine can be a solid option for us here. We can also use it as an opiate sparing and opiate reducing agent, right? Adding ketamine to opiates or vice versa, we can start to wade into multimodal analgesia, and in doing so, we can reduce the overall requirements of all the types of analgesics for our patients. Have a patient who is much more comfortable at lower doses of everything instead of requiring higher doses to achieve the same analgesic effect. If we start to mix and match and cross the streams, we can use lower doses of everything. Okay. Now, last but not least, trauma patients, right? Especially if we have a trauma patient who is quite ill, right? They've either hemorrhaged or they've had, we think they're at risk of compromised hemodynamics by adding opiates, whether we're thinking morphine or fentanyl, right? Ketamine can really benefit the patient here because it is so much more vasostable than both of those agents. Okay, so that may be a primary example of a time when you would pull ketamine in a frontline capacity. So, just as ketamine could be beneficial in certain situations, it can also be harmful in others. So, we'll kind of go through this little bit of a list. First one that comes to mind is our MI or ACS suspect patients. Ketamine can precipitate a sympathetic surge, and that sympathetic surge can increase your myocardial oxygen demand. Might not be the best option in our ACS suspect patients. Never say never, but it certainly wouldn't be my first choice. Right. Now, our schizophrenic patients, we do not fully understand the mechanisms here, but what we do know is that even in well-controlled, well-medicated patients who have been stable for months, years, even decades, a single dose of ketamine has been associated with a precipitation of this patient's particular psychoses. Okay. Again, we do not know why, but ketamine seems to really be able to destabilize our controlled schizophrenic patients. So it is not recommended in these patients unless we are looking at emergent sedation, right? Because at that point we've gone through to sedation, we've just turned everything off. We're stable-ish. Right. Now, we're not talking about sedation in general here, but this is giving us foundational knowledge should this become an option at a later date. Right? Same thing with hallucinogenic ingestions, right? So a patient who's on a peyote trip or they, taken some acid, or even ketamine in its recreational form, right? But the patient's having a trip of some sort, adding more of an agent that can cause further dissociation and precipitate those hallucinations or that psychoperceptual effect worse. Again, not really recommended, again, unless we're going to that emergent sedation. Okay, at that point we would be okay. Now, a patient that's in uncompensated or decompensated shock, right? If we have not adequately resuscitated a patient, ketamine ultimately is a sedative, and it will cause a worsening of that patient's vital signs. We do have to resuscitate patients. On another note, ketamine can be a bit of an early warning system for us. If you have a patient that looks sick but seems to be holding their own, and you give a dose of ketamine in its analgesic form and you start to see their vital signs trend down, that's warning us that this patient is maximally expended in their intrinsic compensatory mechanisms, right? And now they don't have anything left to give. If we continue with this, we can crash the patient. That should be kind of an early warning system for us and let us know to prepare for recess and start to get more resources on hand. Right? Now, it's also not recommended in pregnancy. There's two reasons for this. One is ketamine has been, in active labor, has been shown to precipitate a spontaneous delivery, right? So you can take a patient who's not fully effaced and dilated and ready for delivery, and you can cause that precipitous delivery, causing harm to mom and baby, because it can then increases the strength of the contractions such that it forces that precipitous delivery, right? Really not recommended there. Now, not really through a singular dose, but it has been shown to cause fetal brain malformations with repeated dosing. So in that sense, it is not recommended in general pregnancy because we do not know where that safety line is, right? We don't know if one dose is safe, two doses are safe, a month is safe, an isolated event. Ultimately, we don't know what would cause damage to the fetal brain, and so it's really not recommended in that setting, especially during the fetal development. Okay, so just overall not recommended in pregnancy, has a lot of risk for harm. So we would strongly caution you to steer away from it in those settings. Okay. Now, we've talked about the risks, the benefits, but now we want to look at how do we administer ketamine, right? What's our routes, what's our dose? How do we get this done? Right? So, administering IV or IO, right? We're going to see our effects very quickly over 30 to 90 seconds. Right? So whether we're looking for analgesia or anesthesia, we'll start to see that effect very quickly, and we'll know if we're effective. Right? IM is a little bit different here, depending on the dose. Lower dose, longer time to effect. Larger dose, shorter time to effect. Right? So we have quite a window there. So by definition, the analgesic dosing for ketamine is lower dose, so it's going to be longer to take effect in analgesic dosing. Should we go to anesthesia and need to take somebody down in like an emergent sedation, we should see that in a much faster form, but we're providing a higher dose with much more availability of absorption, right? Right. Now, intranasal is kind of a wild card. 2 to 8 minutes, right? That's quite the range for it in the intranasal dosing, but there's something that we also have to consider here. Remember the ton of bricks slide that I presented earlier, and any of our parenteral routes, as soon as it takes effect, you're going to know it's going to take effect. Intranasal is much different. We only have anywhere between 25 and 50% bioavailability through this route. So It may take longer to take effect, and we're going to have a lessened effect. So if you're dosing a patient intranasally, we are really recommending that you aim on the higher side of dosing. Something to keep in mind is that our colleagues in BC, our PCP colleagues in BC, are administering intranasal fentanyl as part of their analgesic arsenal. And their initial dose calls for 0.75 milligrams per kilo. And they have had some pretty decent effect with this. Right? They do have some association with adverse events, but the majority of those being some nausea, vomiting, or a subjective complaint of patients feeling a little bit disembodied. But they haven't had any worse events than that. Right? So on the high side of dosing, if we were to give a patient 0.75 milligrams per kilo intranasal, at the low end of things at 25%, we're looking around 0.15 milligrams per kilo. And if we go to that 50% of the 0.75, right, we're getting 0.35, 0.36 milligrams per kilo, right, and still sitting nicely in that analgesic range. Right, so that's not a bad spot to shoot for potentially. So when we start to talk more about our dosing, intranasally we have quite the nice range to deal with, 0.5 to 1 milligram per kilo, recalling that our colleagues in BC start at 0.75 milligrams per kilo, so it's dead center of what we're allowed to do. So we're allowed to choose our range, and then our repeats can follow up basically half of what we started initially, every 10 to 15 minutes as needed. Right? We don't have a maximum there, but that puts us nicely in this range. Now we can see that we can get into some trouble at the bottom end of that partial dissociation. That is a pretty rare occurrence, but that's if we were to continuously pull out our maximal doses and keep administering high dose to the patient. If we sit in that nice mid-range, quite often we are going to we are going to cover off the analgesic components for our patient, but we may start to tickle the lower end of the recreational side there and give our patients kind of a pleasant sensation. Some feel a little bit nauseous, and that's totally fine. You are absolutely within your bounds to pre-medicate your patients with an antiemetic. As well, they may just find themselves enjoying a nice trip. Right? So if they end up on the low end of that recreational scale, right, think good thoughts, and basically help your patient have a nice, pleasant experience. Help them feel happy, warm feelings, because that's kind of what ketamine does. Okay, it sounds hokey, but it works. Now, when we start to look at our parenteral dosing, right, IV, IO, and IM, right, we have 0.1 to 0.5 milligrams per kilo as our initial dose, and we can repeat within that same range every 10 to 15 minutes as required. But what we're strongly recommending is that we stay on the lower side of that, because we can always add more. Right? Giving a maximal dose of 0.5 milligrams per kilo puts us right up here strongly into that recreational dosing and puts us potentially at the low end of that partial dissociation where we give our patient a bad trip. We have to remember that 0.5 milligram per kilo is a maximum dose every 10 minutes. We are well within our bounds to titrate and start at 0.1 milligram per kilo and add that every 2 to 3 minutes. So I can give a patient their 0.1 milligram per kilo based on their weight and wait a couple of minutes. If they need a little bit more, I give them another 0.1 milligram per kilo, and I can continuously add up until I either hit my maximum or I achieve my effect. Right? I'm just titrating to effect for my patient. I can always add more, but I can't take away. So if we start low and add up, we can control the dose and wave off if we're starting to get into the danger zone or start to dissociate our patient and cause some problems. Okay. Now, for IV-IO administration, I cannot emphasize this point enough. We must administer this medication dead slow. Okay. The reason we have to do this is we can get ourselves into a couple of problems. The first one isn't a major issue, but if we give ketamine too fast, okay, we can cause some transient apnea. Now, even in large doses, this effect is self-limiting, and the long case reports really put us at about 45 seconds of apnea. But we can avoid this simply by pushing the medication over about 90 seconds. Right? So if we are just to administer our dose nice and slow, 60 to 90 seconds, and go nice and easy, we can avoid this complication. The other one is that, again, by administering this medication rapidly, IV-IO, we can cause laryngospasm. Laryngospasm's a problem because now we don't have an airway, right? We just shut it down. So one of the primary means to fix this, if we do cause that laryngospasm, is to do what's called a Larsen maneuver. And that's where you take a jaw thrust, and then you take your fingers and you put them behind the jaw in that pressure point, where usually someone in your family stuck their finger when you were a kid just to see you wince away, or in elementary school. But you stick your finger in there and you intentionally try and cause that painful stimuli, because it stimulates a nerve cluster that when you perform a jaw thrust will lift the epiglottis up off of the larynx and again restore that airway. Right? So this is a primary maneuver, the Larsen maneuver. Okay. Now, ketamine is a high alert medication by our EMS formulary, and as such requires an independent double check by both practitioners on scene, right? So both paramedics on scene have to double check this medication, or we have to do that timeout, right? Check our medication dose, calculate everything, do something different, come back and recheck your own dose if you don't have a partner that you are able to verify this with, right? Now, ketamine and its ability to play with others in the sandbox. Ketamine and acetaminophen, good friends. They'll make sandcastles all day long. Bring in their good friend NSAIDs and they will all play together happily, right? They are great friends in the sandbox. Our inhaled anesthetics, nitrous oxide, right, works wonderfully, right? They play very well with each other. The only time we have to get a little bit worried is when we bring opiates and opioids into the mix. And it's not even because of ketamine. Ketamine plays well with everybody. The one that we have to worry about is nitrous oxide and fentanyl. Those two mixed together can precipitate hypotension, right? So that's about the only thing that we have to worry about there. Ketamine makes friends with everybody, can make for a very happy patient, a well analgesed, comfortable patient. Right. So we'll just take this as a bit of a case example. So we have this patient here, and unfortunately, they're having a bad day, right? No doctor, but that does not look right, right? So on scene, we come to this patient, and we realize, we have to make them comfortable. We have to do something about this break. So we look at things, and yeah, it's totally appropriate to start off with some NSAIDs or acetaminophen. Are we thinking that's going to make a difference right away? No, but it is going to help down the road, right? So then maybe we give our patient, if it's appropriate, right, an inhaled anesthetic. Entonox, if we have it, great. They can start to use that as PRN analgesia. And then we add some kind of opiate or opioid. Morphine, fentanyl, whatever we have on hand, whatever is carried. And if that's still not working, you may very well consider ketamine here as well, and just keep adding on until we get that painful stimulus under control, right? So we get our patient comfortable, we're able to splint them, we're able to manage them and transport. Totally fine, right? Now, we get that patient to the hospital and they got to go down the road, right? They got to go to an orthopedic center to have this leg surgically repaired. So obviously they're appropriately splinted and stabilized. Please ignore the backboard that is in this picture. We didn't make it. So the patient has been appropriately analgesed. They've had some further morphine administered at the hospital. We get on the road. Now that morphine just started to make our patient a little bit stuporous. So as we get on the road, we realize our patient's now having more pain. We're kind of concerned that adding more morphine to this mix will further sedate our patient, potentially cause hemodynamic or cardiorespiratory issues. So maybe this is the right time again to pull ketamine out of the mix, right, and start adding it as our analgesic so that we do not cause untoward effects on our patient, right? We are absolutely allowed to choose the agent that is most appropriate to our patient's condition. Okay, so just a little bit of food for thought, give us an idea, right? Now again, remembering that ketamine works primarily through the inhibition of glutamate, right, or it's as that NMDA antagonist right at the dorsal horn and the insertion into the spinal column, right? Ketamine works there for us. But we can start to look and consider our multimodal analgesics, right? Opioids act all along the nervous transmission and in the brain itself at the pain center in trying to deaden that transmission and reduce the pain signaling to the pain center. Same with our alpha-2 agonists, right? That's where we see acetaminophen come into the mix. right? NSAIDs also have a little bit of play there. They also work directly at the site of trauma. So anything that is going to be COX mediated or prostaglandin mediated, right? We get that inflammatory response there. That's where NSAIDs play, right? So we can start to pick and choose agents and start to use them together to start to pick what is appropriate for our patients, right? Depending on the stimulus and the type of pain that they're feeling, right? Now, yes, we can send patients on a little bit of a trip, but there are things to do to mediate this here. Because the vast majority of these trips, really, it's kind of like a mind over matter. So if we do put a patient into that spot where they're starting to feel a little bit dissociated, right, they can have those euphoric sensations. As hippie as it sounds, it really depends a lot on your state of mind. So before we start administering ketamine to patients, or if we're starting to administer more frequent doses to a patient, start to get them into the right state of mind. Get them to think about their family, their happy place. Where was your last favorite vacation? Good experiences they've had. Is there a type of music that they like? Right? Because if they go into a bit of a trip having good feelings, they are essentially going to have a wonderful lucid dream that they're just going to love, right? They're going to have a wonderful time. Good feelings, good trip. But we start to get a little bit concerned, right, when the good trip turns to this, right? Now we hit the nightmare phase. What do we have to do? We have to be calm, right? We have to keep ourselves calm, speak calmly, everything that we can, reduce all those extrasensory inputs, no lights, no sirens, slow the transport down, turn the radios down. If you've got music going up front, shut it off, right? Every kind of extrasensory input we need to reduce, right? We get into trouble with the nightmare, right? We need to get some help. When we talk about getting help, we're talking about midazolam, right? When ketamine's a problem, midazolam becomes the answer. So at this point, we want to start adding small aliquots of midazolam nice and calmly to our patient, 0.5 milligram, 1 milligram IV at a time, right? To start opposing the force that is being exerted, or the psychoperceptual event that this patient is experiencing. Okay, so for any problem ketamine, midazolam becomes the answer. Right? Now, it's not that we are suppressing what the patient is perceiving. We're just making it to the point that they don't care, right? They're comfortable and don't care, right? And now we want to titrate, titrate, titrate. We do not want to use midazolam as a slam, right? Anything over 2.5 milligrams in a single IV push puts us into strong anesthesia territory where we can risk cardiorespiratory compromise. So that 60 to 90 seconds push for your midazolam dose, that's the fastest that we would ever recommend pushing midazolam. What we really encourage is adding midazolam 1 milligram every 30 seconds, 1 milligram a minute, and titrate to effect for our patient's safety and for our safety. Right? We don't want to cause a recess if there doesn't need to be one. So one further thing that we kind of need to point out, there is some association between ketamine and cannabis use with violent emergence reactions. And we don't know why. This is primarily from anesthesia OR literature, but what we find, and we don't know the difference, we're not sure what the full mechanism is here. So one patient will go in, they'll be inducted for their procedure with ketamine, come through it with flying colors, no issues. The next patient will go in, be inducted with ketamine, and within 45 seconds, they will be pulling out their lines, fighting you on the table, completely uncooperative. And we don't know why, but we do know that this association sits with cannabis use, and more frequently with recent cannabis use within, the last 2 to 3 days. Okay. Again, not sure why, just something to be aware of. Again, so if this becomes a problem, midazolam becomes your answer. Right? Problem with ketamine, midazolam's the answer. Right? And that's it, folks. Right? So if you have any questions, we would strongly encourage you to reach out to a member of the clinical team and ask for some clarification. We're here. Use us. We're happy to help. All right. Have a great day.